Hello and welcome to this month's IMV Imaging Journal Club. I'm Harriet, one of the members of the clinical team here at IMV Imaging, and this month I'll be discussing the paper Diagnosing Imaging Findings in a Referral Population of Dogs Diagnosed with Immune-Mediated Hemolytic Anemia. If this is your first time joining us, then welcome and thank you for tuning in. Just a small amount of information about IMV Imaging Journal Club. These are produced every month on demand and typically cover a range of topics associated with diagnostic imaging. If you have any questions, queries or suggestions, please pop them in the Q&A box or send us an email to clinical@imv-imaging.com. So back to this month's Journal Club article. As I previously mentioned, I will be discussing the diagnostic imaging findings in a referral population of dogs diagnosed with immune-mediated hemolytic anemia. This study included 50 cases seen during a 3-year period between 2015 and 2018 at Pride Veterinary Referral Centre in Derby. Immune-mediated hemolytic anemia, or IMHA as it's more commonly known, is one of the most common autoimmune diseases in dogs. It typically results in severe anemia that develops acutely and is caused by the production of antibodies targeting red blood cells. These antibodies either cause activation of the complement cascade, resulting in intravascular lysis of red blood cells, or opsonize red blood cells, causing phagocytosis by the monocyte phagocyte system in the liver and spleen. So the cause. So what are the possible underlying causes for immune-mediated hemolytic anemia? Well, IMHA is most commonly a primary condition, i.e. a primary autoimmune disease without detectable underlying cause, but sometimes it can be secondary and triggered by another disease or exposure to drugs or toxins. There is also a genetic susceptibility component to this disease, as evidenced by the high prevalence in certain breeds such as Cocker Spaniels. Possible triggers for IMHA include infectious causes such as Babesia, Bartonella, hemotrophic mycoplasma, Ehrlichia, and more rarely Anaplasma and Lepto. Worm infestations such as hookworms, Trichuris vulpus, or Diphtheria can also cause IMHA. Neoplastic diseases, there are many which have been known to trigger IMHA, but notably lymphoma and leukemia. Medication reactions, particularly cephalosporins, penicillins, trimethoprim, sulfonamide, methimazole, carprofen, and levamisole. Vaccinations, this one is controversial, but there can be an adverse reaction in some individuals. Venom from snakes and bees, and neonatal isoerythrolysis as seen in puppies. The aim of this study was to 1. Provide a detailed description, and 2. Provide a cytological characterization of abnormalities documented via diagnostic imaging used for screening of dogs for the underlying conditions which may trigger IMHA. So, looking at the method, this was a retrospective study using the medical records from 2015 to 2018 for all dogs that were diagnosed with IMHA and underwent both thoracic and abdominal imaging as part of their diagnostic workup. Medical records, primary CR images, radiographs and images from ultrasound studies, as well as medical reports were used. All data was assessed by 2 board-certified internal medicine specialists and 1 board-certified veterinary radiologist. To be included, the dogs had to be diagnosed with IMHA following the diagnostic criteria outlined by the ACVIM consensus statement. Dogs had to present with a moderate to severe anemia. The hematocrit level had to be less than 30, with 2 or more laboratory signs of immune-mediated erythrocyte destruction, such as a positive direct Coombs test, a positive saline agglutination test, and or the presence of spirocytosis on blood smear evaluation. They also needed to present with at least 1 clinical sign associated with hemolysis, such as hyperbilirubinemia, bilirubinuria, icterus, hemoglobinemia, hemoglobinuria, or erythrocyte ghosts. The following additional information also needed to be available, including the results of thoracic and abdominal imaging, full clinical history, physical examination findings, the results of a complete blood count, biochemistry profile, and the results of complete urinalysis, which also included culture, and all had to be performed within the first 24 hours of admission. Dogs were excluded if there was a lack of a definitive diagnosis for IMHA or if the diagnostic imaging was not performed or reviewed by a board-certified radiologist. So what diagnostic imaging was performed? Well, thoracic radiographs were required using a digital radiography system, with the views including at least 2 orthogonal projections for all dogs, with some patients having both lateral projections performed. Most dogs were sedated for this procedure. Abdominal ultrasound examinations were performed or supervised by a board-certified radiologist using either a GE Logic S7 or a GE Vivid 7 ultrasound machine. Transducer type and frequency were selected based on patient size, conformation, and imaging characteristics. Patients were sedated during the procedure and positioned in either dorsal or lateral currency based on the imager's preference. Six patients underwent CT examinations, which included both the thorax and the abdomen, using a 16-slice CT scanner. All patients were either sedated or under general anesthesia and positioned in ventral currency for the procedure. For all dogs, the CT images were required prior and at 45 to 60 seconds post-intravenous injection of iohexol, commonly known as Omnipaque, via a pressure injector. All images were then reviewed by a board-certified radiologist. The choice of the imaging modality was at the discretion of the supervising clinician and owner, and therefore not all patients received the same diagnostic imaging modalities. Ultrasound-guided FNAs were also collected in 27 out of the 50 dogs. Patients were either sedated or under general anesthesia for the collection of tissue samples. Non-aspiration technique using a 22-gauge needle attached to a 5 ml syringe was used for all patients. FNAs obtained from organs with abnormal imaging findings were then reviewed by a board-certified pathologist. So for data recording, continuous data was reported as medians, range, and interquartile range. Categorical data was reported as frequencies and percentages. So moving on to the results that they obtained, a total of 50 dogs fulfilled the inclusion criteria. The median age of the patients at presentation was 6.3 years, but ranged from 7 months to 11.4 years, with an interquartile range of 4.1 to 8.3. The group included 25 neutered females, 9 entire females, 8 entire males, and 8 castrated males. There were a variety of breeds, including the study, notably Cocker Spaniels. If you remember that they're back from the beginning, they have a slight predilection for IMHA and were the most common breed in this study. But it also included Labradors, Staffordshire Bull Terriers, English Springer Spaniels, Hungarian Vizslas, Shih Tzus, Collies, and others. All dogs were anemic on presentation with a median PCV of 17.8% and ranged from 7.5 to 29 with an interquartile range of 13 to 22. Anemia was considered regenerative in 43 dogs and non-regenerative in the remaining 7. Regenerative is defined as having a reticulocyte count over 60,000. The median reticulocyte count was 154 times 10 to the power of 9 per litre. A Coombs test was performed in 33 dogs with 26 positive and 7 negative. A positive Coombs test is consistent with the presence of antibodies on the red blood cells and IMHA. Saline agglutination test was performed in 41 dogs with 38 positive and 3 negative. A positive saline agglutination test indicates the red blood cells have surface antibodies consistent with IMHA. Importantly, a positive saline autoagglutination test or a Coombs test is indicative of IMHA, but it does not indicate whether that IMHA is either primary or secondary to an underlying condition. Mild to prominent spherocytosis was also documented in 33 out of 50 blood smears obtained. So moving on to results of biochemistry in urine. So medium serum concentrations of alkaline phosphatase, or ALP as we know it, was increased at 160 units per litre, ranging from 37 to over 2,000. 40 out of 50 dogs had ALP concentrations above the reference range, even though the median values of all other biochemical parameters were within their retrospective reference range. But others included total bilirubin will have ranged from 0 to over 1,000 across the 50 dogs, and ALT ranged from 0 to over 5,000 units per litre across the sample. 31 dogs were tested for vector-borne diseases, with only one testing positive for Ehrlichia. Urinalysis was performed in all 50 dogs and revealed bilirubin urea in 38, hemoglobin urea in 31, and proteinuria in 37, with a median UPC of 1.27. 4 out of 50 dogs had a positive urine culture, with E. coli isolated in 3 dogs and staph and strep species each isolated in 1 dog. Bone marrow samples were taken from 2 dogs, one revealing a round cell tumour with myelofibrosis, and the others showed cytological changes compatible with immune-mediated process involving the red blood cells. One dog was diagnosed with a cutaneous B-cell lymphoma after FNA samples were taken of its subcutaneous skin lesions. Thoracic and abdominal imaging was carried out in all 50 dogs, and of which CT scans of the thorax and abdomen were only performed in 6, with the remaining 44 receiving thoracic radiography and abdominal ultrasound. Clinical findings of the thoracic cavity were unremarkable in 40 dogs, and clinical findings of the abdominal cavity were unremarkable in 7 of the total 50 dogs. Of the 10 dogs noted to have thoracic disease, the most common findings included cardiomegaly, lymphadenopathy, mild pleural effusion, and pleural thickening. The most common abdominal findings included hepatomegaly, peritoneal effusion, gallbladder wall thickening, gallbladder sludge, splenic nodules, diffuse steatitis, lymphadenopathy, hyperechoic pancreas, and splenomegaly. And here is just, I know it's very small, but the results table from the abdominal findings on ultrasound or CT in the sample size of dogs. In the next slide, we show 3 images from 2 dogs that underwent abdominal CT scans. They are 2 different dogs, the top row being one and then the lower row being another. In the first dog on the upper row, it shows the multiplanar reconstruction CT images of a dog with hepatomegaly in the soft tissue algorithm. The first image is the sagittal view of the abdominal cavity. Note the caudal displacement of the gastric axis and caudal ventral margins of the liver, which have rounded edges. The second image is a dorsal view, where thickening of the gallbladder is evident. In the image below, which is a post-contrast transverse view in the soft tissue algorithm, is the cranial abdomen of a dog with the gallbladder at the level of the liver, as indicated by the white arrows. You can see here there is obvious thickening to the dorsal wall of this gallbladder. And the portal vein, caudal vena cava, and aorta are also labelled in this image. Other diagnostic results of this study included those gained from ultrasound-guided FNAs, which were in 27 out of 50 dogs. Splenic FNAs were obtained in 18 dogs presenting with splenomegaly, splenic nodules, and/or lymphadenopathy. Hepatic FNAs were obtained from 18 dogs presenting with hepatomegaly, hepatic nodules, hyperechoic liver parenchyma, gallbladder wall thickening, and/or gallbladder sludge. Abdominal lymph node FNAs were collected in 3 dogs with abdominal lymphadenopathy. The most common pathological change found in the liver and splenic samples collected was extramedullary hematopoiesis, followed by cholestatic changes. Cholecystocentesis with biocytology and culture was performed in 9 out of 21 dogs with gallbladder wall edema and/or sludge. This number is a little confusing, as if you remember back to the previous slide with the abdominal imaging results table, there was no gallbladder wall edema listed as a finding, only gallbladder wall thickening, which was found in 16 patients, which, in addition to the documented gallbladder sludge, would make a total of 30 dogs rather than 21. It would be interesting to know the number of dogs in this study that the authors documented with gallbladder wall edema rather than gallbladder wall thickening. Biocytology was unremarkable in 7 dogs in which samples were taken, but bilirubin crystals and bacteria were identified in 1 sample each. Bile culture in 6 dogs was negative and in 3 dogs was positive, with Enterococcus species, Streptococcus species, and multi-resistant Klebsiella in 1 sample each. Peritoneal effusion was sampled in 3 out of 19 dogs and identified as a modified transtate in all 3. However, the remaining 15 dogs identified with peritoneal effusion were not sampled, and therefore the type of effusion could not be confirmed. IMHA was considered associative in 16 out of the 50 dogs. Comorbidities were established via abdominal imaging alone in 7 out of 16. 6 of these dogs had pancreatic changes compatible with pancreatitis, and 1 dog incidentally had gastric foreign bodies. Abdominal imaging with cytology or urinalysis established a coincidental comorbidity in 4 out of 16 dogs, 3 of which had bacteremia and 1 had a bacterial cystitis. Urinalysis, blood work, and cytology alone provided the final diagnosis in 5 out of 16 dogs. 2 had bacterial cystitis, 1 had a lichia, and 1 dog had a cutaneous lymphoma and bone marrow round cell tumour. No comorbidities were established with thoracic imaging. So moving on to our discussion. So in this study of dogs confirmed with IMHA, it is reported that no significant comorbidities were documented using thoracic imaging. The cardiomegaly identified in 4 dogs was suspected to be indirectly related to anemia, and the resulting increased preload decreased afterload and sympathetic nervous system activation, which all subsequently led to volume overload. From other studies, it has been documented that administration of blood products and pulmonary thromboembolisms with secondary pulmonary hypertension has also been associated with cardiomegaly in dogs diagnosed with IMHA. The thoracic lymphadenopathy and mild pleural effusion, which were documented in 4 and 1 dog respectively, were not further characterized and were assumed to just be associated with systemic inflammation and pulmonary thromboembolisms. Abdominal imaging findings showed abnormalities in 43 of the dogs in this study alone, without further characterization via FNA. The most common hepatic and splenic changes documented were hepatomegaly, hepatic nodules, splenomegaly, and splenic nodules. Of the 54% of dogs whose liver and spleen were further sampled, extramedullary hematopoiesis, likely caused by regenerative erythroid response associated with the hypoxia and anemia, was noted. The presence of abdominal changes could raise the concern that there is underlying neoplastic cause, as we know that neoplasia can be a trigger for IMHA in dogs. But the evidence from this study is that and other studies is that IMHA associated with systemic neoplasia is currently lacking, and no neoplastic disease was documented in any of the lymphatic, splenic, or liver samples reviewed in the study. Although peritoneal effusion was reported in 18 dogs, only 3 were further sampled and diagnosed as a modified transtate. There are many possible causes associated with the formation of modified transdates, including ongoing systemic inflammation, thromboembolic events, increased hydrostatic pressure, neoplasia, vasculitis, and decreased lymphatic drainage. Unfortunately, due to only 16% of the peritoneal effusion sampled and further analysed in the study, it is difficult to draw a conclusion on the cause of the remaining 84% of dogs diagnosed with peritoneal effusion. The gallbladder wall thickening and gallbladder wall sludge were other common findings in the study. Gallbladder wall edema has recently been identified with dogs presenting with IMHA, but it can also occur in other cases of intra-abdominal inflammatory processes, anaphylaxis, and cardiac disease. The presence of gallbladder sludge is more difficult to interpret since up to 50% of healthy dogs can have a small amount of gallbladder sludge, and it is considered merely an incidental finding. However, in this study, 3 of the dogs documented with gallbladder wall thickening and/or sludge were positive for Bacteria. This finding is difficult to interpret due to 1, the small sample, 2, the lack of differentiation between how many dogs had solely gallbladder wall thickening and how many dogs had solely gallbladder sludge, and how many dogs had both, which underwent cholecystocentesis. And 3, Bacteria is reported in approximately 10% of the healthy dog population. Furthermore, it is difficult to interpret this finding in dogs with IMHA due to the overlapping clinical signs of IMHA and gallbladder disease, and due to the lack of a control group, no causality can be proven between the presence of Bacteria within a gallbladder and IMHA. Based on these findings and the severe complications that can arise from ultrasound-guided cholecystocentesis, it is advised to select dogs for this process based on strong clinical evidence of gallbladder disease rather than on suspicions of IMHA. Pancreatic and peripancreatic changes suggestive pancreatitis were documented in 7 out of 50 patients. However, pancreatic disease is challenging to diagnose alone from diagnostic imaging without concurrent pancreatic lipase assay tests, which were not obtained in the study. In addition, information regarding pancreatic changes could only be extrapolated from static ultrasound images and ultrasound reports in the study. And from this, the authors have concluded that there is an association between IMHA and pancreatic changes in dogs, but there is currently no causality between these two conditions. So moving on to the limitations. So the limitations of this study come from a lack of standardization of imaging modalities and interpretation of findings in context of the different sensitivities and specificities of CT versus radiography and ultrasound. Although abdominal ultrasound is more sensitive when assessing the gastrointestinal tract compared to CT, as mentioned in a previous study, the sensitivity of abdominal CT is far greater when patient size exceeds 25 kilos, as would be the case for a number of dogs included in the study. Furthermore, the sensitivity of thoracic CT is greater than that of thoracic radiography, and not all patients underwent both modalities. Therefore, it is difficult to say whether CT may have identified lesions which were not seen on thoracic radiography. Furthermore, there was no standardization for the selection of abnormalities and patients for tissue sampling, as this was based upon the discretion of the primary clinician, and therefore not all patients received the same. There was no standardization for the evaluation of ultrasound reports and images. Furthermore, the original studies of the patients were not assessed. Instead, it was just still images and ultrasound reports. Further to this, it was only a single veterinary radiologist reviewing the images, which could naturally just introduce bias. There was a lack of a control population in the study, which makes the interpretations of findings in a small sample size difficult. All cases were seen at the same referral hospital in the United Kingdom, and the results of this study may not be fully representable for all dogs associated with associative IMHA. And last but not least, as I mentioned, it was only a single radiologist reviewing the images, which, as I said, could introduce bias into the study. So in conclusion, this study found that thoracic imaging in dogs with IMHA is less likely to provide clinically relevant information regarding triggering comorbidities. A similar conclusion was made regarding the routine sampling of liver and spleen due to concerns about underlying neoplastic disease, which was not documented in any of the dogs with hepatosplenomegaly in the study. Even though abdominal imaging provided information about associated disease, the causality between that disease and IMHA could not be proven in this study sample. Future studies into the relevance of Bacteria is necessary, its occurrence in healthy dogs and its occurrence in IMHA dogs, as immunosuppression, which we would do with IMHA cases, and routine sampling of gallbladders can potentially lead to life-threatening complications in dogs. So that's it. I just want to say thank you for taking the time to tune into this month's Journal Club. If you have any questions, please feel free to pop them in the Q&A box or drop us an email at the address displayed on the screen. We'll be back next month for another episode of IMV Imaging Journal Club. So until then, it's a goodbye from me. Goodbye.